Good afternoon, everybody. This is Amanda Pierce-Kelly with the Association of Clinicians for the Underserved. I'm so happy to have everyone with us today, especially in light of everything that is going on. We wanted to just take a little bit of time to walk through ACU's response and support for our network. We're very fortunate to be joined by some really wonderful colleagues and partners, and we are just about to get started here. Bear with us as we get through the technology. I know that to start, we're going to be joined by ACU's board president, Dr. FELIX NUNEZ. He is a family physician, and he has a master's in health services. He is the Inland Empire Director for Molina Healthcare in California, and he is an extremely dedicated and wonderful leader for ACU. FELIX, are you live? Can you hear us? Bear with us here for 1 second, guys. We're trying to make the technology work. All right. So looking for FELIX. We're going to give him 1 more minute to unmute here. FELIX, are you there?
It does look like he might be called in, and so I can't locate him as a user to pop him to live, but we can work on getting him back on the line with us shortly.
Okay. Well, in the meantime, let me look really quick here. Sorry, guys, for the delay. We're going to give it 1 second. FELIX, we're going to try to bring you through, but what I can say on FELIX's behalf is that the board of directors for ACU is extremely dedicated and committed to making sure that all of our clinicians and our network as a whole, everyone who's serving on the front line, is taken care of and supported. ACU is working tirelessly to make sure that we're connecting people on the front lines with resources and support. We're working very hard on the advocacy. We're going to go into this in depth later. But the board really is such an incredible voice for ACU and source of leadership in terms of guiding the work that we're doing and making sure that all of ACU's work and goals are really to fulfill our mission to make sure we're supporting clinicians on the ground across the board, working in those underserved communities. So hopefully we'll have FELIX with us.
I think I'm on now. Is that right?
Here you are. Good.
I'm so sorry.
That's okay. FELIX, please. The mic is yours.
I'm sorry. I heard everything you said, and thank you for that introduction. Everyone, thank you so much for joining us today on this call. This is really fantastic. I just wanted to spend just a quick moment, Amanda, if that's just to thank everyone who's on the front lines and working so hard in the midst of all this uncertainty. I know some folks are really in the midst of it, especially folks out in areas like New York and Boston. So I'm in Los Angeles. I work for a health plan here in Los Angeles, and everyone is bracing for what's coming. So again, I'm so proud of the work that everyone's doing. ACU. If you haven't gone to our website, clinicians.org, please feel free to do so. There's more information up there. Amanda, there's links, correct, on the website for folks that have interest or want additional information?
There are, correct. We are maintaining a page dedicated to ongoing resources and links, so always feel free to go to the clinicians.org website. Yeah.
So that's a great resource if folks want to learn more about the work that ACU does. And just as a quick background, Amanda, I didn't hear if you got into that, but I just wanted to provide a little bit of background on ACU, the work that we do, in case folks are interested in learning more about us and joining us and our efforts. So ACU was founded by alumni of the National Health Service Corps. Our main advocacy focus is for providers in low-income and underserved populations. We do that through advocating for more funding for the National Health Service Corps. Our dream is to have everyone who wants to serve in a low-income and underserved community. We want them to be funded and supported. We don't want any medical students, dental students, nursing students to not do that kind of work because of financial burden. So that's our ultimate goal as an organization. Join us if you can by coming over to the clinicians.org page. You'll learn more about the work that we do, and hopefully everyone stays safe. Please protect yourselves and your families. That's about all I have.
Thank you so much, Felix. Well, we know that you're working really hard to make sure that people have access to the resources and supports that they need. We're grateful for your leadership, so thank you so much.
Thank you. And I'm going to jump off the call, folks, but thanks again. And my contact information, I believe, my contact information is on the clinicians.org page. So please feel free to reach out to me if I can be of any assistance to any of y'all. God bless everyone. Take care.
Thanks, Felix. All right. So to keep us moving, if we can now move our slides. Sorry, here we go. So today's agenda, we do want to walk through what ACU is doing in terms of advocacy and support. We are joined by a fantastic colleague, Kathy Bowden, who I'll introduce properly when we get there, but she's really going to walk us through telehealth guidance and review. We understand so much the importance of making sure that our providers on the ground, everybody on the front lines is leveraging telehealth right now, and there's just a lot of nuances to all of the changes that have occurred since we've been dealing with this pandemic, and so Kathy will be joining us to speak to that. We also want to walk through resources to support folks on the ground, specifically around moral injury. There's been a lot of news and information that's come out from other parts of the world that have been coping with this a little bit longer than we have, and just some of the challenges that providers on the front lines have been faced with. And so we want to connect folks with resources to support you on that front, and then we want to leave plenty of time for questions. So with that, we'll go ahead and get started here. To begin, ACU is working very, very hard to make sure that our voice, our needs, and those of the folks on the front line, all of you, are understood on Capitol Hill. So the things that we've been advocating for most heavily is funding for the National Health Service Corps in the shape of immediate funding, $930 million, and long-term funding, $3 billion over 3 years. We knew before this started that the need for more support via the National Health Service Corps was huge, that there is so much unmet need. There's so much need for additional support for staffing, recruitment, retention, the Corps being one of the best ways to do that on the ground in underserved communities. So that immediate funding is something that we're advocating for very hard to make sure that there's an infusion to address this pandemic. We're very aware and looking to deal with the fact that we know that there are going to be provider illnesses and a lot of issues with burnout and just general continued issues, if not inflamed issues with retention especially. And so we're pushing Congress to make sure that there is an immediate infusion of funding. We're also looking long-term. The reality is we need to be able to ensure that there's stable funding for the National Health Service Corps to support clinicians and the practices that they're serving in those underserved communities. And so again, these are the two key asks that we've been pushing for with good success and response, honestly, from Congress. As you can imagine, this changes every hour, but every hour we're pretty much on the phone and emailing with congressional leadership to make sure that this is understood and linked to the stimulus package that they're working on right now. In addition to that, we know, and I'm so grateful to so many of you who have been in touch directly to communicate with us the importance for immediate supplies in the form of PPEs, test kits, and 95 masks. So this is something that we've also communicated over and over and over again, not just the need, but also that there needs to be thought given to allocating those resources specifically to underserved communities and making sure that the folks on the front line have both access but ongoing supports in this space, because we know that this is going to continue to ramp up. So that message is getting through. They have not yet made any decisions, but I do expect we'll get answers very soon, hopefully in the next day or so. Other things that we've been focused on in terms of advocacy on Capitol Hill, flexibility and liability coverage for providers, specifically National Health Corps providers. So addressing the need to enable National Health Service Corps providers to be able to cross state lines, for example, to make sure that liability coverage follows them to wherever they're going, and other elements that exist within a normal situation for National Health Service Corps provider relating to the number of hours they can dedicate to clinical versus admin time, flexibility around practice and providing care within and without a HRSA. These elements so far have been very well received and included in all of the various packages that we've seen coming out. And so that message is getting through loud and clear. And they are working overtime to make sure that the appropriate flexibility and coverage are there to ensure that providers can go and provide care where they need it, however they need it, in the best way possible. And then the last piece that we've taken very seriously and communicated over and over again on the Hill is the need for telehealth flexibility and adequate reimbursement. Kathy is going to get into this in greater detail, so I'm not going to spend a ton of time here, but suffice it to say that the understanding and recognition around the need for flexibility relative to telehealth is very, very clear. And in fact, there's been a lot of effort and measures already taken to make sure that that flexibility exists really across the board. However, there is still work to be done on the reimbursement side, and ACU, along with several others, have been working hard to voice the need to make sure that the reimbursement element of this is not just taken into account, but written into law to make sure that whatever package exists going forward covers this part of our work, and that providers can provide this kind of care, do the telehealth that they need to, without fear of lost reimbursements to keep their operations going. So this is another one where it changes hour to hour. I will say for telehealth, it tends to improve hour to hour, so I'm very optimistic that we're going to see positive results within the next couple of days as we see a final package come from Congress. And I'm going to go through these relatively quickly because I do want to leave time for questions at the end here. But again, just know that we'll be taking questions along the way. And just from a housekeeping perspective, if you have questions immediately, please feel free to type those into the chat. We can take those towards the end. So some of the other work that the ACU is doing to support clinicians on the front line is really working with an incredible set of partners. We're very, very grateful and very, very lucky to have partners that are not just supportive of ACU, but really understand what's going on the ground. And not just understand it, they're willing to put everything they have into making sure that the support and the resources are there for people who are on the front lines, everyone on the call now, and our network at large. So what does that look like specifically? ACU is working with providers and organizations to make sure people can have access to resources that are very difficult to find right now. Things like PPEs, N95 masks, hand sanitizer, cleaning and sanitation items. This is another one where honestly the inventory changes and the access changes day to day. But the wonderful thing is that through our partners, we are able to plug provider organizations into whatever inventory exists, oftentimes where we've been running into dead ends left, right, and center elsewhere. And so ACU has been in the progress just in the last few days of trying to gather information from our network around what is it that you need. You know, let us know what your order would look like, give us your wish list, and then we are now in the process of trying to connect those dots. This is entirely possible because of these partners. ACU is not just grateful, but at this moment in time, it's our partners that are really enabling this work, and so we can't express our gratitude enough. It actually extends beyond just the front line in terms of the clinical side of this. These same partners are also working with us to look at what is it that our patients need. There has, for a very obvious and necessary reason, been total focus on the needs of our providers and clinicians. But the other side of this is that there are so many needs in our underserved communities for patients. And so that's everything from non-perishable food items, household goods, basic medications, cleaning supplies. And so again, we'll be in the process, we've begun, but we're in the process of trying to collect that information as well. So if you are a provider in an underserved community, if you're working at an organization, of course, in an underserved community, and you're aware of these needs on the patient side, please also, we want to hear about that. We want to try and to do our best to work with our partners to create a workflow to get these items to these underserved communities as well. The other thing that I would flag is that, again, this same partnership, they are already doing their best and so much to make sure that once we identify the needs, we can have a coordinated response, but it's not just in the form of these items I've just walked through. They're also providing direct financial support to organizations on the front lines. The best way for us to connect those dots is for you all to be in touch with ACU to express your scenario and your situation. And so that's everything from letting us know what items you need, what would that order look like, what do your patients need, and then your financial situation, your operational situation, and what types of supports and resources specifically could help you to continue to fulfill the needs of your underserved community. I think the last piece that I would just flag in terms of the partnership that we've been so grateful to have is that there's a lot of information sharing going on. And so as we're hearing from our network about your needs, we're bringing that back to our partners. We're also sharing with them the work that we're doing on the advocacy side. They are able to amplify for us in all of these areas. And so it's, you know, if I could, I feel like I have a magic wand, because honestly, the way that they've been able to step in and provide support is better than we could have dreamed, particularly in terms of accessing some of the items that have been so difficult for folks on the front line to identify and access. So on this, if you have questions, if you have items that you need, you'll see toward the end here how you can be in touch with me to let me know what you need, ACU, what you need. But again, please, the more information you can share, the more we can do to try to put together the items and just the overall package that you're going to need to make this work over the next week, and hopefully days and weeks, and we'll see how long this is going to take, but I don't think it'll be a short endeavor. So the other thing I want to flag for folks is that ACU's work is going to continue in the midst of everything going on with the COVID-19 pandemic. There is a ton of programming across ACU that will continue. We're very dedicated and committed to making sure that we're supporting our network and our organizations regardless of what's happening. Though that being said, we are taking into account the COVID-19 pandemic. So in terms of workforce and the STAR 2 Center, we're looking at how we need to shift our lens a bit to incorporate the changes that we're experiencing in terms of workforce recruitment, retention, training, technical assistance, all of it, and applying that COVID-19 lens to be fair to you all. This is another one where we want to hear from you. You know, I think everyone is rightly in the weeds of just trying to make it through and navigate. But as we continue, all of us in our work, as we have to, we want to be responsive to that as well. But please bear in mind that we are still very much committed to making sure that our ongoing work persists. That's everything from the STAR 2 Center to our vision services, our suicide safer care programming, and of course our policy and advocacy, which is front and center across the board right now. So I can't say it enough, ACU is here to help you. You heard me mention that we want to hear from you in terms of your requests. What does it look like in terms of what you might need in PPEs, N95, sanitizer, patient items, you name it. We also want to be able to be responsive to you in terms of questions and information sharing, or just issues and concerns that you have. So here's my contact information, email, cell phone, whatever is easiest. You can text me even, and I will put the slide up again at the end. But truly, we want to be here to support your needs. We're doing the best that we can with all of the information that you guys have been providing, but we also understand that it changes day to day and that the situation is very much in flux. So please don't be shy. Come to us with your needs, share that information. We will do our very best to turn things around as quickly as we can and continue on from there. And I would just echo what Felix said, that we're very grateful for our partners, but I think the true heroes right now are those of you that are serving on the front lines and making sure that we're getting through this as a nation and as a planet, really, at this point. So thank you a million times for the work that you're doing in every capacity. So with that, I am going to welcome Kathy Bowden. She is an expert of more than 25 years experience with FQHC and physician billing. She has broad experience with public health and private practice, where she is integral to coding and compliance, education, training, and clinical providers, practice, and office staff members. She's masterful in this field in helping providers and practices to optimize reimbursement through correct coding and through documentation. She's joining us now to walk us through billing and coding telehealth guidance in this time of COVID-19. So Kathy, I will turn it over to you.
Thank you, Amanda, and good afternoon, everybody. The following slides that we're going to discuss today for billing and coding pertain to telehealth guidance for COVID-19, okay? And we all know that it changes basically by the hour, so it just about drives you crazy to try to keep up with all of the guidance that they put out there for the billing and coding piece of it. Make sure that you do keep abreast of the information that is provided, because it does change daily. We have some centers who have just said they're kind of just going to hold their claims, okay? So I think that's a good idea to hold those claims, just because codes are changing, place of service is changing, guidance is changing. So keep that in mind. And with that said, you know, this presentation today is based on information that was provided yesterday. So yes, it has changed as of today. Next slide. And we'll talk about kind of like the timeline. We'll discuss some the telehealth consent requirements. We'll review telehealth guidance provided by HRSA. We'll talk about some Medicaid procedure codes and reimbursement rates. We'll look at some Medicare guidance, and we created a coding and billing resource for Medicaid and Medicare, and most of this pertains to FQHC, so I wanted to share that. And I've also provided a copy to Amanda so that she can send out to all the participants, and my contact information will be at the end of this presentation. So of course, if you have any questions, I'm available, happy to help on anything pertaining to coding or billing for the telehealth during the public health emergency of COVID-19. Okay, next slide. So January 30th, World Health Organization declared 2019 a public health emergency. January 31st, World Health Organization convened an emergency meeting to discuss creation of specific codes for the coronavirus. February the 11th, World Health Organization announced the official name for coronavirus, which is the COVID-19. March the 5th, we received some guidance on the lab tests, CPT codes, HCPCS codes, and some fact sheets. March 17th, DCH for Georgia released guidance on telehealth services, and those revisions were updated on March the 18th. So that just kind of shows you that daily there are changes. And then on March the 18th, DCH provided 2 procedure codes as mandated by CMS. Next slide. In order to conduct a patient encounter as a telehealth service, the patient must initiate the service and provide consent to be treated virtually. The consent must be documented in the medical record and include the patient's explicit agreement to be treated via telehealth rather than an in-face encounter. This is critical, guys. You have to make sure that your EMR documents that that patient initiated the visit and that they give you a verbal consent. Your verbal consent should include the following elements: the date of consent, time of consent, consenting responsible party before initiation of service, the rendering provider, elect services as a virtual telehealth encounter, and verbal attestation by the patient. I cannot express enough that documentation is key here. The more documentation, the better. Less, not so good. So overkill is okay, so please make sure that you document. If you can get an in-person consent, those are available. If you need an in-person consent, we can pull those off the website and send you a copy of that. But most everybody is encouraging not to come into the office, so most of them are going to be verbal anyway. So just keep that in mind. Make sure your documentation supports what the requirements are. Okay, so HRSA guidance: services from a location that is not an in-scope service site. So we were asked the question, can a provider provide services from home? A couple of providers were quarantined. And so HRSA answered the question, yes, they can, as long as the services being provided via telehealth is within the health center's approved scope of project, recorded on Form 5A, and the clinician delivering the service is a health center provider, and the individual receiving the service is a health center patient, okay? So you just have to make sure all those conditions are met. And of course, that has changed since the update on 3/17/2020, as far as the patient having to be a health center patient. Okay, and is it okay to perform an initial consultation with a patient via telehealth? In light of the public health emergency, health center providers may provide triage services, including initial consultation as part of primary care to patients or to individuals that intend to become a patient of the health center. Okay. Next slide. Okay. So your in-scope telehealth services to individuals who are not patients of FQHCs. So is it okay for health centers to provide in-scope services through telehealth to individuals who are not current health center patients? The answer is yes. During the duration of this public health emergency, health center providers may deliver in-scope services via telehealth to individuals who have not previously presented for care at a health center and who are not current patients of the health center. Okay, and then it goes on the list. Telehealth visits are within the scope of project if the individual receives an in-scope required or additional health service, the provider documents the service in a patient medical record consistent with appropriate standards of practice, and the provider is physically located at the health center service site or some other location on behalf of the health center, for example, the provider's home, emergency operations center, etc. Okay, next slide. Medicaid supporting the use of telehealth in diagnosis and treatment. So Medicaid expanded the use of telehealth by waiving the telehealth services originating site limits. For those that are not familiar with the term originating site, the originating site is the location where the member will receive services through a telecommunications system. And we provided a list of originating site locations. Keep in mind when you're deciphering some of this information, when it states FQHCs cannot, an O2 service is not an FQHC. Place of service of 50 is an FQHC, okay? So if you're billing for an FQHC and you're providing telehealth services and you have a place of service O2, that's fee for service, okay? So, and I'm sure your billing staff are aware of that terminology, and it can be confusing, and sometimes I have to tell myself, hey, don't forget FQHC and place of service 50 versus O2. They are allowing telehealth services to be provided by the following modalities, which is telephone communication, use of webcam or other audio and video technology, as well as video cell phone communication. Something very important here is that your documentation rules still apply. There are no exceptions to this. So if it's a level 3, you got to make sure that your elements support billing a level 3, that the medical necessity is there to support a level 3. So documentation still has to be the same as if you were seeing them in the office and you was billing a regular E&M service. So make sure your documentation supports the level of service you're billing and that the medical necessity supports the level of service that you're actually billing. Okay, the next slide. Effective February the 1st, 2020, DCH updated GAMIS with the following 2 procedure codes as mandated by CMS. So your CPT code U0002 is for dates of service 2/1/2020 through 3/12/2020, and the reimbursement rate is $51.31. So you would not want to use the CPT code for Medicaid U0002 after March the 12th. CPT code 87635 for dates of service 3/13, and then there is no expiration date right now because we don't know when this is going to end. So make sure your system is set up. As of 3/13, you have a new CPT code for Medicaid, okay? There are no diagnosis restrictions, and it can be billed as primary as both primary and or emergency, and limit to 1 unit per date of service. Okay, next slide. So for Medicare, effective for services starting March the 6th and for the duration of COVID-19, Medicare will make payment for Medicare telehealth services furnished to patients in broader circumstances. These visits are considered the same as in-person visits and are paid at the same rate as regular in-person visits. That is your fee for service. Starting March the 6th and for the duration of the COVID-19 public health emergency, Medicare will make payment for professional services furnished to beneficiaries in all areas of the country in all settings. And while they must generally travel to be located in certain types of originating sites, such as physician's office, skilled nursing facilities, or hospitals for the visit, effective for services starting March the 6th and for the duration of the COVID-19 public health emergency, Medicare will make payment for Medicare telehealth services furnished to beneficiaries in any healthcare facility and in their home. The Medicare coinsurance and deductible would generally apply to these services. However, HHS is providing flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by federal healthcare programs. And I know I read that slide word for word, but I think it's very important for you to hear that. And again, Medicare is changing every day as well. So they are allowing a lot of flexibility. And as Amanda said, I think there is more flexibility to come. Okay, next slide. So Medicare has your HCPCS code of U001 to bill for tests and track new codes of the virus. This code is used specifically for CDC testing laboratories to test patients for the SARS-CoV-2. The second HCPCS code U0002, announced March the 6th, allows laboratories to bill for non-CDC laboratory tests. Again, that's important. Know which HCPCS code you should be using to bill for. Critical news that was put out by Medicare: the claims processing systems will be able to accept these codes starting April the 1st for dates of service on or after February the 4th. So if you submit a claim before April the 1st with these codes on it, it's going to get kicked back. So if you can delay your billing until everything is straightened out, at least until April the 1st, to see if, you know, any guidance has come out either way or the other as to how these should be billed, that would be great. I think it would cause you, it cause you a lot less heartache and pain to hold those claims just a little bit longer. And next slide. So this is the Excel document that we created for the FQHCs, and there are several tabs on this document. And so the first tab is going to be your coding and billing guidance, and it's by payer, so Medicaid, Medicare, and then we talk about virtual check-in visits and e-visits. And so it just lists, you know, what the service is, what your CPT code or HCPCS code is, patient relationship with the provider, the practitioner that can actually bill the service, how telehealth is allowed to be performed, and it is different by payer, okay? And the HCPCS or CPT codes for the procedures, the place of service that you would use to bill, modifiers, and are they waiving the originating site limitations, your revenue codes, and the services allowed. So to date, they're stating that preventive health screenings are allowed, but we have not seen any of the preventive health screening codes that are allowed. So we've not published any of that information yet. So I'm trying to find out, you know, if you're allowing us to perform these preventive health screenings, what codes are we allowed to bill on the claims? And of course, the reimbursement is all fee for service right now. Okay, one of the important things that I wanted to print out about third-party payers, most of your third-party payers are waiving your copays and applying no cost sharing for all diagnostic testing related to the COVID-19. So we have started checking with each individual payer. So on this document, there is a tab for third-party payers, and so we've talked to Aetna, we've talked to Anthem, we've talked to Cigna and Humana. So we're still working down the list to see, you know, what their guidance is, and of course, their guidance will change. I think Cigna has changed twice, Anthem once, and so of course you'll see dates on these updates on the third-party payer page so that you can see what has changed and what they're actually allowing. A lot more flexibility coming, I promise you. Okay, and then the next slide. So all the information provided today are in these links right here. And of course, if you need any additional detail, I'm happy to help. The next slide. And here is my contact information. Thank you.
Thank you so much, Kathy, honestly. And I have to give a shout out and a thank you to the Georgia Primary Care Association for lending you to us to be able to cover this information. I know a lot of people are trying to sort through this, and so I really appreciate you walking everything through. We will make sure that we put Kathy's slides and the grid of information she referenced. We'll make that available on the clinicians.org website. So rest assured, we will make sure that all of the information you just heard that she walked through will be available there. And the other thing that I would say is that the information is kind of ongoing. It is changing and evolving, particularly in the telehealth space. And so as you're working through your own operations, as you have questions, don't be shy to be in touch with us. And if we can't answer, then we will connect you with the experts, Kathy or others who can help. With that, I want to turn the presentation over to Sabrina Edgington. And Sabrina, you should have control of the slides now at this point. Sabrina is our Director of Learning and Curriculum Design at the ACU. She is, hopefully she's going to get us to where we need to be in terms of the slides. Sabrina is such an incredible member of our team. She has been such a huge support as we ourselves navigate through the COVID-19 pandemic. And she is going to speak to everybody about all of the resources that are going to be needed on the ground for those working on the front line, and in particular, what that looks like in terms of moral injury. So with that, Sabrina, I'll turn it over to you.
Great, thank you, Amanda. Good afternoon, everyone, and thank you for participating in this webinar. As Amanda said, my name is Sabrina Edgington. I'm the Director of Learning and Curriculum Design at ACU. And as Amanda mentioned, we want to take the time to talk about how we can take care of the clinicians who are taking care of us. And so many of you have probably read articles or at least seen the headlines about the life and death decisions that doctors in Italy have had to make due to limited resources. And Italian doctors have even posted videos warning other countries of what happens when you lack the resources to help everyone. And while we hope none of our clinicians have to be faced with this kind of decision, we should be prepared to help support them if they do. So today I want to talk to you about moral injury and steps that we can take to address this among clinicians. So for those of you who are unfamiliar with the term moral injury, it actually comes from the military to describe soldiers' responses to having to perform, witness, or fail to prevent actions that go against their moral beliefs. And this term is increasingly being used in healthcare to describe the impact on clinicians who know what care a patient needs but are unable to provide it due to constraints that are beyond their control. So with COVID-19, we already know that the hard clinicians that decisions are the hard clinical decisions that might be made due to the need to ration resources. So clinicians do what they do because they have deep personal values and moral beliefs that led them to be of service to others. So you can imagine how a clinician will feel when a patient who may have an opportunity to live is left to perish because there are no more ventilators. So in order to address moral injury, it's important to understand how it's different from other types of responses that clinicians experience in the work environment, because we're likely to fall short if we try to address moral injury in the same way that we address other responses, such as burnout and secondary trauma. So here you can see that each type of response is actually caused by different situations. So with secondary trauma, this is really coming from that individual connection with patients and being exposed to traumatic life experiences. With burnout, organizational factors such as unclear job expectations, administrative burden, and dysfunctional workplace are examples that cause this. And with moral distress and moral injury, the factors are generally systemic, and they prevent practitioners from doing what is right and good. And this can come from systemic policies that limit the scope of services available to patients. With COVID-19, it can come from the lack of capacity in our healthcare system to care for all who need it. It's the struggle between what is available and what should be done according to one's sense of goodness and humanity. So for those of you who are wondering about the difference between moral distress and moral injury, I feel like this quote is helpful. It says, every time we're forced to make a decision that contravenes our patient's best interests, we feel a sting of moral injustice. And over time, these repetitive insults amass into moral injury. So each sting of moral injustice creates moral distress. And over time, this can lead to moral injury, having significant and profound emotional and even physical harm on our clinicians. So what actions can we take? The first thing we can do is create an organizational culture that recognizes and responds to moral injury. So educate your staff on this phenomenon and encourage open discussion. One way to do this is by creating space and time for group discussions led by an experienced facilitator, since conversations can be very emotionally driven. The American Association of Critical Care Nurses came up with a really great framework for talking about this one-to-one. It's called the 4 A's: ask, affirm, assess, and act. So if you begin noticing that a clinician seems distant, if they seem distressed, for example, they're easily frustrated, they're distant, they're describing feelings of guilt, shame, or remorse, ask them if they'd like to talk about what's contributing to those feelings. And then provide affirmation, recognizing the reality of what's causing them to feel as they do. And then assess the situation. Is the source of distress unique to the individual, or is it something bigger that's impacting everyone? Is it something that can be addressed easily, or will you need to pull together your team to work on a strategy? And then act, implement those strategies to address the source of moral distress. So in addition to creating a culture that recognizes and responds to moral injury, we need to really create opportunities for clinicians to participate in social change and community outreach. So the idea is to help clinicians engage in opportunities to impact the source of their moral distress before it leads to moral injury. And we can do this by creating opportunities for clinicians to provide input on advocacy priorities, engaging clinicians in advocacy efforts and awareness campaigns by asking them to share their experiences with policymakers, and then giving clinicians time to participate in coalitions, committees, and other groups addressing systemic causes of poor health. And finally, prioritize self-care. However, and that's a big however, asking clinicians to engage in self-care activities without acting at the organizational and systemic levels can seem patronizing and tone deaf. And frankly, clinicians are tired of being told to meditate and do yoga. So while helpful, self-care activities do nothing to solve the real problem, and these strategies alone have been criticized as victim blaming. Nonetheless, self-care combined with organizational and systemic efforts can be helpful. And some things that your organization can do is to encourage the use of counseling resources and employee assistance programs, adopt policies that promote and support self-care, like requiring personal days off would be a good example, and work with staff to create a wellness plan to guide self-care during and after this crisis. Many clinicians are being told that they can't take personal time during this crisis. So how is your organization going to help them process all of this when it's over and give them the space to recover? If you're interested in learning more about moral injury, I recommend the following 3 resources. Team Care Connections, which is a project of Arizona State University, A.T. Still University, and the National Association of Community Health Centers, just released a really cool interactive digital journal on moral injury. I'm also a big fan of Wendy Dean and Simon Talbot, who I quoted a lot in this presentation. They have a nonprofit called Moral Injury of Healthcare, which has a great resource list. And then the University of Kentucky established the Moral Distress Education Project. They've collected videos of clinicians sharing their stories of moral distress and injury in the field to help spread awareness of this important topic. And of course, you can always reach out to ACU if you need support addressing moral injury among your clinicians. So as I end my portion of this webinar, I want to remind us all that as clinicians do their part to care for us, let's do our part to care for them. Be safe, stay healthy, and please let us know if we can help you in any way. Thank you so much, and back to you, Amanda.
Thank you so much, Sabrina. Man, here we go. Hopefully you guys can see my screen, or as we go through the technology one last time here, I'm going to throw up my contact information for folks. Let's see. Well, I'm going to leave it right where it is because I think you guys can see it. What I want to say, and I want to take some questions. We've got a good amount of time left, which I'm happy about. It really is every walk of healthcare clinician, and I want to say thank you to every walk of healthcare clinician right now, our behavioral and mental health folks, nurses, NPs, doctors, dentists who I know have had to take a step back. I mean, literally every walk is doing their part right now to make sure that we can get ahead of this pandemic. And I'm so grateful and I'm so proud. And frankly, I'm also very grateful that ACU is doing the work that it is to try to support you guys, and we want to do more. And big thanks to our partners who are enabling that. So I want to stop and just take some questions. Mariah, do we have any questions that have come in that we can take up?
Sure, and I just want to take one moment here to just remind everybody, don't worry, I know there was a lot of information, but we will be sending this all out to you. If you have any questions for us now, feel free to put them in the chat box or the Q&A box, and I'll read them out and we'll get them answered for you. So we had one question come in saying, I noticed LMHC, licensed mental health counselors, were not listed on those who can bill. Will LMHCs be able to bill for mental health services?
That's a fantastic question. And I think we're going to need to get back to you on that one, Jody. My inclination in some of the reading that I've done is yes, but I want to make absolutely positive. So what we can do is, thank you very much for flagging the question. And we actually just posted, thanks to one of our fantastic board members, a great resource on this front. It's on the .org page, but let me double check because I want to make sure I give you the right information to be sure that, in fact, you are able to bill. So we will follow up with you, and thank you for flagging.
And we had another question come in. It scooted away from me for a second. In the portion of the presentation about location for FQHCs, are we not supposed to be O2 location?
That's another great question. I don't know, Kathy, if you're still on and you can respond to that. That's another one where we might have to circle back because I don't know that I have the detail on that one to be able to get you guys the information. Again, some of this, forgive me if I don't have the answer right off the bat. Part of what I want to make sure of right now is that we get you guys the right information, and because some of this stuff is so fluid and changing so frequently, I don't want to give you the wrong information.
Right.
Kathy, do you have anything to chime in there?
Is this an FQHC asking the question?
I believe so.
Okay, so if it's an FQHC right now, for the distance site, you would put place of service 02.
Well, there you go.
Not 50. Okay.
Okay. Mariah, do you have another question?
I'm not seeing any questions coming in right now. If you do have any questions, feel free to pop them in the chat and we'll leave it open here for just a bit longer.
Okay, thank you. Well, a couple of the other things I know that I've seen come in just during the presentation, we are going to make the slides and the recording available on the clinicians.org website. So please, we will send something out following this up to make sure that people have easy access to the links. But you can always go to the website, and we'll be updating all of the resources that we've mentioned continuously on the website, the resources page, but then also as we're able to gather additional information, we'll put that up there as well. And again, you see my information available to you guys here. If you have questions, issues, concerns, and also we're still collecting those requests for some of those items that you see there. So please be in touch with me directly with any of your needs, including additional support and resources in terms of as we continue to navigate this. So we're doing our best to make sure today's presentation was basically just to cover as much as we could around the supports that we're trying to push out, the policy and the advocacy piece, some technical assistance, obviously from Kathy on the telehealth side. But we know there's going to be additional needs going forward. So the more we hear from you, the more we're able to be responsive. So please don't be shy. And I will say, Mariah, any last call on questions for now?
More comments than questions. Thank you all for your feedback so far.
Okay. Well, I will just say thank you once again. You know, ACU is, as you heard, we are a transdisciplinary organization, and we are united in a common mission to improve the health of America's underserved populations. I know that everybody joining us today is doing that hard work. You guys are on the front lines. You are supporting the clinicians if you yourself are not the ones actually providing the care. We're so grateful for you. We're here to help. We're all in this together, and I know we'll get through it. So thank you so much. We will give you guys 10 minutes back, hopefully to go back to your day and continue that great work, and we're here for you. So thank you very much. Enjoy.
Thanks, everybody.
Thank you.